All right, well, I think we're going to go to our live case right now. Amir, are you there? Can you hear me? This is Eric.
Yeah, Eric, I hear you.
There we go. Yeah, we can see you.
Okay. Before I tell you about the last case, I want to show you the angiogram from the very first case we did. I didn't get to finish to show you the finished product. Can you see the angio?
No, not yet.
Yeah, there we go.
Okay, no.
Okay. This is after we finished with the lytic therapy, and this segment of the artery, I didn't do anything. No balloon, no nothing, just a lytic. Can I see the next one? And here is where we did a atherectomy, balloon angioplasty, and I put a stent in. Next one. If you remember, there was stenosis of the popliteal artery. We dilated that, but I want you to look at down in the basket is right in the common tibia peroneal trunk, which is totally occluding the trunk because of the a lot of the emboli were in the basket. Next one, if there is any. No? Okay. Now, I kept the best for the last. This lady, patient of ours, is a well-kept 90-year-old female who complains of claudication. We worked on her back in May of 2012. At that time, she had total occlusion of the left superficial femoral and diffuse stenosis of the right on both sides. We did atherectomy and balloon dilatation, and we put on both sides a stent in. She went on after 6 months. In November, she occluded the right side. So we brought her back, and we did atherectomy, angioplasty, and go to the next angio and the next one. And we put a Vivon stent graft on the right femoral artery. Can we see the next one? That's the Vivon on the other side that we put in last November. Now, at that time, SFA on the left side was patent. Now she's back with occlusion of the left SFA and also proximal popliteal. Can I see that one? Now here is the next one. No, this is not the angio. You're mixing up with the first case we did. Number 4. Okay, that is her angiogram. On the left side, you see there is a IDEV stent in a SFA, which is totally occluded. Now, below these stents, she also has occlusion of the popliteal artery down to just above the knee. Next one. And this is her runoff. Okay? Now let's go to the very last angio. Here is the proximal SFA on the left side, which is just open for maybe about 10 centimeters. And now that's where I have the I have this catheter in. This is Trave laser. It's a catheter by it is same as quick cross catheter, And I have the catheter there and a wire. This is the glide wire, right to the tip of the catheter. This is by EV3. And here is where the occlusion is. So we broke through that. And this is the IDEF.
Looks like that's going pretty easily.
It's going pretty easy because it's a recent occlusion.
Right, I think that's...
What I'm concerned about, Eric, is when I get below the stent, where the popliteal is occluded, down to, okay, here is where it's giving me a little bit hard time.
Yeah, I think that the thing to recognize with these is when the catheter is going very easily and you pat yourself on the back and you think, oh, look at how good I'm doing, but usually that means it's almost all thrombus, and you have to be careful with these, and so sometimes the easy ones can be the most difficult ones. And oftentimes the same thing is with the bypass graft, or there'll be a focal area of restenosis, maybe at the distal stent edge, and the entire thing will clot off. So you may have a 30 centimeter occlusion, but it's 29 centimeters of clot and 1 centimeter of focal scar tissue.
Yeah, like you can see it in this, he's having a lot of trouble going through the distal stent. Indicate that's the reason for failure of this therapy. It's nothing to do with the SFA. SFA is just thrombosis because the blood has been swirling around there. There's no outflow.
Yeah.
So once he gets through the outflow, then we have to make the decision how we're going to treat this. Whether we're going to use the atherectomy, whether you angiojet, how you're going to aspirate that thrombus, because there's a high risk here of distal embolization with that much clot burden.
Yeah, and that's exactly where I was getting at, is that, there was some debate in the last session about using filters and not using filters, and Tom Davis and I have gone back and forth for a long time on that subject, but this is one clear area where I think there's no question I would use a filter for this.
As long as you have it, you ought to use it.
Yeah.
Okay, let's do an angio before we go any further to see our runoff.
As you saw, he made a loop and then basically slid his catheter on top of that loop. And that's extremely important because sometimes in chronic occlusion, these stents, you have an ability to get the wire behind the stent. So stent is thrombosing, you're going to go sub-stent and then try to re-enter the artery, and that can create a lot more issues than trying to go through the lumen of that stent.
The other thing I like to do when I'm advancing that loop is to, as you advance the loop, kind of keep the loop small. So keep on the flexible part of the wire, not get into the stiff part where it'll really open up. That's where you can get the large dissections. But it looks like you're making good progress there. Does that feel like it's going pretty easily now?
It was okay after I made the loop. I mean, okay, let's see that. See, you have to be very careful with this. And when you make the loop right where you want to go to distal runoff, so what I do here, I'll take the loop out. Okay? Now see that if intralumen or mainly subintimal. Here I like to, no, don't wait, don't move. Let's see the angio.
Yep. I think that's excellent. That's excellent technique there. You want to really avoid extending that. I think that's all clot distal to the stent edge, and it's probably reconstituting at that first collateral branch.
Yeah, so we're okay here. We take this one, inject some contrast, make sure we are all right. Then we're going to put a distal protection. We do the angiojet to see if there was any clot. And see, she has an anomaly of the distal arteries.
Yes. Her posterior tibial artery comes off quite
Yeah.
high.
That's posterior tibial. So we want to put our basket just about there.
Amir, how long has she been having symptoms? In other words, how old do you think that clot is? Is that relatively recent, or has it been going on for a few months?
Well, be honest with you, I didn't get to see her immediately after this probably happened. She can't tell me exactly when it happened.
Yeah.
But it's not old, and it's not too old. But even look at the time-wise. We, in December, when we did the left side, right side, the left side was good. I would say maybe probably 2-3 months.
So it's normally decent.
Okay.
Samir, what kind of filter are you going to put down?
A filter is ED3.
Spider.
And the reason I like this, because I can deliver it right through my 4 French catheter.
Mm-hmm.
And as you see here is 6 millimeter basket. And the only bad thing about this, or any distal protection device that is not inserted over the wire, is that it moves. And if you don't watch it, so it may come up and go further down. That's the only shortcoming. But otherwise, this is a very good distal protection. You can put your catheter anywhere you want, then deliver that through the catheter, 4 French. The same, quick cross type catheters that we use. You can deliver it right through that, and you can retrieve it through that catheter too. If you don't have any emboli in it, you can bring it out and you still maintain your axis. So we put that one over here, and
Samir, another question I have here is, because we look at the SFA more or less occluded and your wire went through easy, so there appears to be significant amount of clot burden. Now you're going to do the angiojet. Are you going to utilize any lytic therapy or just go plain simple angiojet?
No, I'm just going with an angiojet now. Be very honest with you, I didn't expect that. I was expecting to be more of, atheromo type occlusion,
Mm-hmm.
and it still, it could be just diffuse disease. That, but we're going to give it the benefit of doubt, and like right now, I have a very hard time to advance this. Now, it doesn't go as easy as it did with the catheter. But anyhow, I'm going to put it down here.
Yeah, I think this is a good strategy to try and declot as much as you can and try and unmask the underlying culprit lesion. And there's a variety of ways you can do this. You can do catheter-directed thrombolysis. You can do power pulse spray. You can use a trellis catheter. You can use ECOS. In a lot of ways, it's kind of treating it like a DVT in a way. And the success of this is going to depend a lot on the age of the clot. If the clot's relatively old and organized, you may not be able to get much out. But I do think it's worth trying this. One of the things
I can't advance this any further. I'm going to.
Yeah, I was worried about it when you were going through it, Amir. I thought that there may be a lesion there, which appeared to be very tight there.
Well, it has to be.
Yeah.
If you look at the stent, even the stent is not expanded as much as the rest of them. So definitely there is a lesion there.
Yeah, another trick here is as far as, I got to become devil's advocate, and that's the only reason I'm sitting here. Uh, there is a surgical approach to this also. Once you have the wire across the lesion, you can actually leave the wire in place and actually expose the femoral artery. And you can actually utilize the 4D catheter over the wire to take the clots out, and then proceed with your endovascular intervention after all the clots are out. One of the advantage with utilizing surgical way is that you'll be able to take out the entire clot. It actually comes out like a snake. And,
Yeah,
artery is usually
yeah.
very clean after that, and you can visualize your lesion very, very nicely. Yes, very easily.
Now, Amir, do you use heparin
she's
or do you use
moving all
Angiomax, or what's your anticoagulation used for these?
Heparin, she was given 5,000 units of heparin. And as I said this morning, we try to maintain ACT of 250 plus. And we repeat the ACT every 20 minutes. And okay, stop that. That's where the artery is narrowed.
So as
Put it
he's
on
going
40.
in and out with that device, there's a high pressure pulse of the heparinized saline solution, which is actually breaking that clot. With a larger bore hole on the other side, it actually sucks out the clots at the same time. So one of the advantages of this therapy, which really works very well in the venous system also, is to remove as much bulk of the clot. Like Eric mentioned, it all depends upon what kind of a clot we are dealing with.
Yeah.
It is a young and soft clot, nearly everything comes out.
One of the problems I have with this is that oftentimes your filter will become filled with clot and debris, and so it's very frequent that you're going to have no flow or slow flow because your filter's full, and that's perfectly fine because that's why the filter's there. But it makes it hard to assess angiographically what your results of your therapy were. So a lot of times what I'll do is I'll take a regular aspiration catheter, like an Export or a Quick Cat, or there's a dozen
20.
different Pronto catheter. I'll take it all the way down the artery. Instead of aspirating, just inject a CC or two of contrast, and you can do an entire arteriogram that way, and then you'll be able to see if you have patency of the vessel or if there's big intraluminal filling defects. Right.
Okay,
Same
it
concept.
looks like we didn't really gain anything. So we're going to, well, if you want to do atherectomy, what the panel recommend?
Well, I would think that the two choices would either be laser or jet stream. I think that Fox Hollow and clot is like cutting jello and is not going to do much, and I don't think that orbital atherectomy is going to do anything, spin that around. But with the jet stream, you have the ability to aspirate, and with the laser, it'll ablate the thrombus. So I think those would be the two ones I would think of.
You might also consider, I don't think you were able to angiojet all the way past what was occluded. Perhaps a small balloon or something so you can get your angiojet all the way down, and then maybe you can have a better idea of what you really have to treat.
That's a great point.
Because you may not have flow, mainly just because you have 4 or 5 centimeters left.
Yeah, I think that's a great point.
Eric, you mentioned the pathway jet stream device. I think in my hands it has worked very well in soft clot.
Yeah.
But when the clot is aged, it has a tendency of basically wrapping around that wire. It doesn't really rotate, and it's got a hard time pulling it back out by leaving the wire access in there.
Sorry, Eric. I'm using exactly what you recommended not to. Can I see the angio? Well,
Fox Hollow,
for
Silverhawk.
any stand 3 stenosis, in my experience, nothing works better than Fox Hollow. We'll turn it on. And since the angiojet here didn't really show a definite evidence of significant clot, So I decided to go with the original plan, which it was to do a atherectomy with Fox Hollow, and after getting some luminal gain and dilate the whole thing, and maybe at that time consider putting a Viabon stent graft in, turn it on.
Yeah, I think that I agree with you, Amir, that Fox Hollow will work well for that distal area at the edge of the stent. It's a little more difficult to cut the thrombus, though.
Yeah, but the thing is that I don't think now we have that much of thrombus. If it was really thrombus, Angiojet should have shown some improvement.
Well, I guess
didn't
I
see
guess it's
anything,
the
really.
it's the definition of whether it's organized thrombus and more of a solid matter now, or a gelatinous type, fresher thrombus. I
Yeah.
mean, I think that's where the crux of the discussion is, because if this is organized and firm, then it should cut it. But if it's more recent and gelatinous type material, it's going to just push it around.
Can you give us something?
Yeah, another thing about the Silverhawk could be helpful is that edge distally where you couldn't get the angiojet. If you can get across that and clean that out, it's probably a distal restenotic spot. Then you can maybe treat you may go back with angiojet. So is that the longer catheter or longer Silverhawk? it
Yeah.
looks like?
That's LXM, yeah. The only bad thing about it is that we won't be able to go all the way to the end. We may have to, are you full? Let's go.
You might have to relocate your
We
filter.
may have to, when we get down there, use the smaller one.
Yeah, that's always my
Okay.
hesitation with the
Now-
long one. You have to have a lot of room at the end if you're using a filter or anything.
Yeah, I'm also fairly liberal with my anticoagulation regimen. I have a very low threshold to use intraarterial ReaPro through like an aspiration catheter. I think that even despite our best efforts with filter devices and other things, there's a tremendous amount of microembolization that gets into the capillary bed, and the drugs are a good way to get down in there. I also wouldn't be afraid to give 5 or 10 milligrams of TPA right into this and just let it sit for a couple minutes and soften it up a little bit. But I think the multi-drug regimen helps really effectively clean out the microembolization that you're going to get as well.
The funny thing is that we got a lot of the atheroma out, and we really didn't get any thrombus out. Can you show this? You see that?
Yeah.
These are all atheroma, very, very little thrombus.
So a lot of restenosis.
It'd be interesting to
Will we
IVUS
go
the
back
artery
in?
too, to see what kind of plaque burden there is. 'Cause maybe there is just a small little lumen, and
Be very, very honest with you. I was going to do that and I totally forgot. I was going to do IVUS before do any procedure as soon as we cross the lesion. I was planning to do IVUS and see what type of the problem we have, but I don't know why I forgot about it and no one said anything to me.
Yeah, I think IVUS is
Even the IVUS man didn't say anything.
I think IVUS is a truly undervalued tool. I mean, there's so much information you can get from it. It really helps appreciate the lesion morphology, potentially why the stent failed, where the restenosis is, whether there's a stent strut that's sticking out somewhere. There's a tremendous amount of information. I have a very, very low tolerance to use IVUS. I think it's very helpful.
I think we all forgot about IVUS because we were just intrigued by the amount of thrombus, which turned out to be nothing.
Yeah. No, I mean, before we get to that, my plan was to put the IVUS in. And I even discussed it, before we go live, that this is what we're going to do. Hold on one second. I don't know if you noticed what I did here too or not. I usually, when I get to the tip of the stent, I try to pass it quickly to make sure I don't catch the tip of the stent. Go ahead.
Amir, how old is that stent?
We put it in May of last year. May of 2012.
So it's a year old.
Okay. Oh. Okay.
Is that nose cone running into the that tight area down below?
Filter is lower.
Not yet. Okay. More filter came out. Oh. Huh. As I said, we have to get a shorter one. Okay. Let me see if I can advance this
what's the
filter and see if we can get to a tight spot. Okay. Go ahead. Yeah. Okay. It's full.
Did that go through that distal segment with much resistance?
It did. Yeah, it sort of jumped.
Yeah. Occasionally you have to pre-dilate
Yeah.
those. I use like a 2 millimeter, 2.5 millimeter balloon just to create a little channel through there.
Yeah, but not larger because you don't want to give up your lumen. The tighter the lumen is, of course, the better cutting you get. Can you rotate that a little bit? Okay. Okay. Here we go. Can you push it in here?
So have you changed the device now to a shorter one?
Not yet.
Not yet.
Can you get me a short one?
Is that a lot of scar tissue?
Yeah, and this end has a little bit more thrombus than the upper portion of it. Go ahead, take this out and get that small one.
So what size device are you putting in now?
I'm going to put a LSM, which is the nose cone is about half of the present one. It is a shorter one. Here we got some thrombus, but we still have a lot of plaques. Yeah. Okay, now let's see if we got any lumen down here. Can you put this on? We're on 28. That's good. Go.
Well, Amir, you may not see any flow through the SFA because we still are, occluded at popliteal
We
level.
still have this.
Yeah,
Yeah.
there's no distal
Yes,
outflow.
correct.
So
Yeah.
one of the tricks to
We
find
don't
out that
have,
is you can put a catheter on top
Yeah,
on the
we
wire.
don't have this to run
Yeah,
off.
and just shoot a picture. So if it retrograde fills the SFA, that means you have achieved your goal there, and then to work on the distal one.
Yeah.
Okay. Put this here. I don't think we're going to get all the way down. Let's see the angio.
Mm-hmm.
Yeah, okay.
Very good. It went through.
Okay, I'm sure once we balloon it, we'll probably get some lumen. Okay, go ahead. Oh. Go ahead. I have a lot less resistant now than I did before. Okay. Okay, I think regardless of what the lumen shows now, I'm going to balloon that. And then since I'm planning to put a vibe on stent graft in, so I'm not very interested to get a perfect lumen.
What length, what size balloon are you going to use?
Well, that's the longest one that I have. I think we even have a 30 cm.
Yeah, there's a few companies now that make 30 centimeter balloons, and
Yeah.
I tell you, it sounds kind of trivial, but that's been one of the best inventions I've seen in a long time. You know, I've been begging and screaming for longer balloons for a number of years, and it makes your life so much easier.
A little bit, you know, save you some time. And also, if you are one of those that like to do balloon dilatation only and don't stent it, it gives you much better and more uniform dilatation. You don't get plaque shift. When a shorter balloon, you know, when you dilate them, you may shift the plaque a little bit higher or lower. With the longer balloon, you don't have that. So we got some more stuff out here. Looks good. Let me make another injection down here. See if we have any runoff. Doesn't look like it. Oh yeah.
There it comes.
Yeah, I see it.
Slow.
There's, it looks like there's your stenosis right
Yeah.
there.
So
Yeah, that's right there.
So I guess the question then
Okay.
is, do you just stent that focal area, or are you going to stent the entire artery?
Well, with Viabond, you can't do that. Viabond is not a stent that you can just stent a segment. You have to cover the whole disease area, or don't use it. You know, if you know, I may change my mind after dilating the whole thing, and see is too much or too long for Viabond, I might change my mind. But if you want to do a Viabond, you have to go from healthy to healthy areas.
So you're in essence creating intraluminal FEMPOP bypass.
Exactly what it is. It's an endoluminal FEMPOP graft. Can I see it? Full angio? Okay, this was our runoff, so, okay. We're going to dilate that.
Let's throw this.
Okay.
Does it look like that's a calcified nodule? I mean, it looks like your stent is slightly underexpanded right there. Do you think it's possible there may have been some calcium that maybe caused that initial lesion to start?
That never did. It never did, yeah, get dilated. I have the ultrasound in for you. And here is, can you show that ultrasound now?
Because the way
Can you hold the wire?
the Silverhawk catheter was kind of jumping through that little segment, it makes me suspicious there may be a stent strut that's underexpanded.
Okay, we're out of stent now. See, these are
There's your collateral.
the atheroma right there. Here doesn't look too bad. Now we can see. It really doesn't look bad here.
No, that's
Further
why.
up is, this is the area that,
There's a cut down
Probably.
at about 5 o'clock. Yeah.
Look at how much residual stuff we have there. Yeah, we still have extensive disease. This is right where we couldn't cross it and was jumping right here. See it throughout stent, you can see how much atheroma is built. The lumen is very tiny here. Look at that.
Yeah. So, Amir, to make the decision to put Viabond will depend upon how do you see the lesion after doing the balloon angioplasty, correct?
Exactly. If you get the luminal gain enough for putting Viabond there.
I think my bias
That's
would be
why I
to-
always go with the Viabond 1 millimeter smaller than the stent that I put in.
Would you consider doing a little more debulking down there? Seems to be quite a bit of junk left. May help you make sure your stent fully expands.
No, I think I'm going to balloon it and see what happens.
Amir, they're talking to me saying that we're going to have to probably wrap up in a few more minutes, so we may not be able to see the final
Okay.
product. But I think that you've
Okay.
made great progress so
Yeah.
far. What would you?
What I'm
so-
going to do is I'm going to dilate that, and then as I said, probably put a Viabond in just like the other side.
Why don't you make sure you take some final pictures and maybe you can show them in a later session
Yeah.
or possibly tomorrow during time if we get some quick time tomorrow.
Here is out of stent. You see, it's even more diseased up here.
That's above the stent right there?
Yeah. Oh,
Correct.
way out of stent. Yeah.
That
Yeah.
was where the proximal cap was up there.
Eric, if you want to cut, what we could do is cut back into Dr. Matarjame after a couple of talks. That way he'll just have some final shots and then we can cut back in.
Okay, that'd be fine.
Yeah. Why don't you go? Yeah. Do a talk and come back, and we'll show you the final one.
We will. All right. Well, let's
Okay.
keep going on the last few talks of the last session here. We have a couple on aorto-iliac and one on renal interventions. Why don't we get started on mine first here? The topic I was asked to talk about is the task classification. Is it still relevant in regards to these lesions? And what is TASC? TASC is a transatlantic inter-society consensus document on the management of peripheral arterial disease. This was first came out in 2000. It was a very comprehensive document that talked a lot about finding the disease, screening, medical management, and then delved into the big issues of, well, how do you treat these? This is early on. There's already been quite a bit of peripheral intervention started, not a lot of data. So they really made a big effort to gather actual data together, decide what should be treated. Created quite a bit of controversy, mainly where it was endovascular versus surgery, which we'll talk about. This is TASC 2000, just to kind of get it, kind of define the four groups. Now, the top group is TASC A, and it says endovascular treatment of choice. And they said basically D, the bottom, surgical treatment of choice. And in the middle, they made these comments that type B, they said, well, if it's if currently endovascular treatment is being used quite a bit, but not a lot of data, and not a lot of data that surgery would be much better. And then they kind of flipped that for type C, saying surgery is used more often, not a lot of data that endovascular would be much better. So this, basically really limited what lesions would be well accepted as endovascular treatment. If you kind of look just quickly about all these lesions, look at the extremes. The type A's were less than 3 centimeter non-occlusive lesions. Type D's, long occlusion over common and external iliac, or any disease that involve the common femoral, which is still an issue I think we'll talk a little bit about. Bilateral external iliac occlusion, I thought that was interesting. They included that. And I think it's mainly because they moved down the tree, the data early on was fairly clear that your restenosis is worse. And that last one there, you notice that it's involving up into the aorta. So aortic involvement, again, kind of a surgical issue. So this was all revised in 2007 with task 2. And just quick, if you look at this, you see a couple things, is that they added a couple little aortic pictures here because they started to talk a little more about what people are doing, which is aortic lesions, aortic narrowing, or as the bottom there, total occlusions, or the other one kind of addressing, if you see the bottom here with an aneurysm, is an aneurysm that you can't treat with an endograft. If there's a lesion, don't go treating it if you're going to have to take them to surgery anyway. So what about the difference between the two? I kind of trying to put these together to kind of see what happened. You see that, and the designation for these, again, A, they said is endovascular, and D, surgical. They did change their language a little bit about the B and C lesions. They said B lesions, endovascular treatment is a preferred treatment for type B, and surgeries is preferred for good risk patients with type C lesions. So this is, we start to really talk about the reality of what we have to deal with every day is, sure, it might be a surgical lesion, but not a surgical patient. And so they loosen that up a little bit. I think that's appropriate. So you can kind of see that they did kind of bring the little bit longer lesions from the B up to A, and they added the two aortic issues, which we'll talk about. So why might these designation not mean as much today? Well, some of those type D lesions are chronic total occlusions, and there's two issues. One, it can't be crossed, or maybe the risk is higher because they can't cross it and can't treat it. But also we have better stents too. Dr. Kumar is going to talk next about covered stents and how that may impact this, and there's some data that may suggest that doing that or using an endograft instead may be worthwhile for some of these. So I think it's probably going to get changed again, but we're going to talk about it. One of the other issues is mortality, the risk of the procedure. In general, endovascular treatments, when you can do it, usually win. Usually they're overall lower risk, but there's always that risk of an iliac perforation, and the worst is if you perforate and you haven't been able to cross it yet, so you can't treat it. That can be bad. An aortobifem graft is very durable, but not a low-risk surgery. So it's a big deal for patients to go through, possibly retroperitoneal or endoscopic efforts may make it lower risk. And really, just a lot of patients just aren't good candidates. So I'm going to skip over these two trials because he's going to talk more about it, but these are covered stent trials in iliacs, and just show you a couple examples of cases I think that are type D lesions that I think were very effectively treated percutaneously, and we can talk about it. So this is a 58-year-old gentleman, young guy, severe bilateral thigh and calf claudication, a couple of years. He had been admitted to the hospital 2 or 3 times, coronary problem each time. And each time they try to cath him, like, dude, you need to get surgery. You have horrible disease and you need surgery. He refused. So he showed up to me for another opinion, and this is this lovely disease he had. So he's got an occluded right common iliac, disease in the left common iliac, disease in the distal aorta, and what's a little bit hard to imagine, and I'm sorry, the CT was from elsewhere and I lost it, but there's a nasty calcified lesion in the mid-aorta, below the renals, very calcified, very narrow, and so the whole combination is, aortobifem sounds like a great idea. They didn't want that. So what we decided is that, you know what, if we can get across this occluded right common iliac safely into the aorta, and we can treat that, an aortoendograft might be helpful, and a unibody graft that can cover everything and preserve the bifurcation might be helpful. So the tricks with that, just kind of planning, is, well, means if we do a unibody endologics graft, we're going to have to pull down the contra limb through all that junk on the right. So we have to think, well, how are we going to do that? What if it doesn't work? What if I can't get it down there? So our idea was if we can get across this, and then we'll put a little bit larger sheath up there. I think it was either a 12 or a larger, such that we can hopefully pull the limb into the sheath and protect it as we pull it all back down. That was our plan. So we couldn't wire it directly, but we did get close, and I pulled out a Pioneer catheter, and it was very nicely, we could see, we went as low as we could in the distal aorta, and we could see the true lumen, and did a re-entry with this. And what's interesting, I think this next picture kind of shows, look at this, how this wire was flipping around in here. It reflected, it kind of bounced off that aortic lesion because it had trouble crossing it, but we got across okay, multiple small balloon, big balloon, kept taking pictures, making sure that dye wasn't where it wasn't supposed to be. And eventually we felt comfortable that we had it treated at the big enough balloon. Then we sized up our sheath, put it up in the aorta, and then we went ahead and put the 17 French sheath for the Endologics device on the left side. And this is just after ballooning everything. I mean, it looks like hell, we can't leave it like that. So we brought and just more ballooning. You see on this one panel here, you can see a little bit better two things. One, you see a little better picture of just how bad that mid-aortic lesion was, just nasty. And then here we are bringing up our sheath to try to put the Endologics device in. And here you see some of the steps here. We've brought the device in. We brought it all the way up, and then we brought it down and protected it the best we could with the sheath to get it through all that crud. But we really aggressively ballooned the right common iliac to really try to make it safe to get it through there. And then we just went ahead and deployed the endograft like normal, and ballooned. And look at, this is a coda balloon on that mid-aortic lesion, and it really had to inflate this aggressively. And, in doing that with a bare metal single stent, I mean, it's just high risk, very big circle of calcium. So we ballooned everything, and this was our final result. We did add on the right side here, we added a big Viabond to kind of continue it down before the internal, the hypo. And it worked very nicely. And then he did great. He felt much better. He eventually had renal artery stenosis, which you can kind of see there. And we had left it alone, but we did relook him about 10 months later because his pressure was out of control. We wanted to stent this. And so we got a nice 10-month follow-up picture, and things actually look even bigger. They look good. And if you're not used to the way the Endologics looks, this cage is on the inside of the graft, fabric's on the outside. So this isn't an endoleak. This is the fabric is up against the wall, and the cage is just sitting there in the middle. Maybe a little bit of leftover compression from all that calcium. So I think this is very reasonable. I think it's going to be very durable. And if you ever, I don't think he's ever going to need surgery for this to replace what we did here. I think he'll do well long term. And the benefit of this versus what we used to do, we try to put some stents in the iliacs, put a big stent in the aorta, try to do it that way. We don't have any gaps there at that distal aorta. It's all covered. It's sealed up with a very durable device. So I think he'll do very well. So another one I want to show you here quick, another case where it's really a TAS D lesion both times. 45-year-old woman, bilateral leg and foot pain, very uncomfortable, a lot of mild ulcerations on the feet. She smoked, and she had no other history. She walked into her primary feeling lousy, and we did a CT on her. I'm like, holy crap, her aorta's closed. I mean, she had somehow got so bad, she closed her aorta. You can see here it stops here. There's a little bit of a channel I'll show you in a minute, and it reconstitutes down here. Now, what's really interesting on her CT is there's no calcium. I mean, this is not a nasty calcified aorta. She's only 45, and there's the little bit of calcium you'll see. I think here I'll show these are some cross sections throughout the aorta. That's just goo. That's clot, and then you get all the way down here, and then it closes a little bit, then it's closed distal aorta. Here's where it bifurcates. A little bit of calcium there, but geez, it's like, where's the lesion? So what we did, we brought her in and took a picture, and we basically wired up the right side first, and the wire would just easily went all the way up to the aorta, wired the left side all the way to the aorta, and with that, we just started angiojetting and got quite a bit of clot out of there. So we angioed like crazy, cleaned it up, ballooned some in the iliacs. And then I looked at it like, she's got atheromatous plaque in the aorta. I think that was her whole source of this. Her iliacs looked really normal. So we put thrombolytics in here. We did fountain catheters on both sides, dripped her overnight, let everything totally clean up, and came back. And with that, her iliacs looked totally stable. She just had this scary lesion. I'm sorry, the picture's not that good. But the question I had, I knew it was narrow in one spot, but it looked like some of this debris was a little spread out. So, and I wish I could tell you what the exact measurement was, but aorta was not that big. So what we did is we put this is a 14 by 80 protege stent. We just placed it across this. It easily filled the aorta. We ballooned, and look at, if you can, I don't know if you can kind of see that little spot over here where the indentation is. Now we found the exact lesion. It was in the mid-distal aorta. And with that, we ballooned this like about 12 balloon and left it alone. And it looked much, much better, and she felt fine. So I think we definitely haven't burned our bridges, and I don't think, this has been a while, and she is not re-stenosed. There was really no disease in her iliacs. I think it was all just clot sitting there. So we'll have to watch to see how she does, and hopefully she'll quit smoking. So anyway, in conclusion, I think everyone agrees on task A lesions. I think task B and C, the rewording is very reasonable. And I think there's two issues I didn't mention in the second half of this. One of is the patient. What's their surgical risk? And the second is, what are the endovascular and surgical capabilities at your institution, and how do they do, and how successful are they? And then the task D is usually, I would agree, I think the same caveat. If they're poor surgical risk, there's nothing wrong with taking some time and trying to treat them endovascularly. I think the leftover part is really the common femoral. A lesion that extends all the way to the common femoral, possibly a hybrid procedure that could be lower risk for the patient, covered stents up above, and an endarterectomy at the groin, that might be a nice option. So.
All right, go ahead and start it up.
All right, well, why don't we go on? Yep.
You want to go back to Amir?
Is he finished up? Yeah, let's see what he's doing.
Hey, Amir, you're live again.
Okay.
You still working? You want us to just come back?
Looks like
Can you hear us?
Is that a Vibon? Could that be?
Can you hear us, Amir?
Yeah.
If you're still working, we can go ahead and do another talk and come back to you in a little bit.
Why don't you do another talk, then I'll show you the final angio.
Thank you, Amir.
All right, Dr. Kumar, why don't you
Yeah,
join us?
sure. Go ahead. No. Don't.
So my task here is to talk about role of covered stent in aortoiliac occlusive disease. Do they perform better than bare metal stents? And I have none to disclose. Bare metal stents have been utilized since 1991, since Palmer's stent was approved. And we have utilized them in aorta and iliac, both arteries, effectively. However, in the beginning, when the devices came out, we were basically treating what Jack just described, task A and task B lesions. But as the time went on, we realized that over the years, these bare metal stents tend not to perform as well as we thought they will. So John Kent actually looked at 19 non-randomized cohort studies, and he looked at 1,711 patients. All the bare metal stent placed with technical success of almost 86 to 100%, and clinical symptoms were improved in 83 to 100%. Mortality was seen in very little number of cases, 1.2 to 6.7, mainly due to perforations, and lower complication rate later on, but early phase, we saw a very high complication rate of distal embolization to approximately 45%. 4 to 5 years there, primary patency was 60 to 86%, and secondary patency was 80 to 98% in most cases, which are task A and task B lesions. So the idea was, yes, we can perform aortoiliac intervention with bare metal stents, although they have a good patency rates, about up to 4 years. However, long-term patency is definitely inferior to surgical procedures. So why does this actually happen? If the bare metal stent tend to perform so well, what is happening? We actually get the atheroma prolapse through the intrices of these stents, and then new intimal hyperplasia develops on top of that, leading to restenosis, occlusion, and then questionable long-term durability. What can be done? Well, Roger Edelman raised this question in 1995. They actually took the slotted and corrugated tubes and covered them with a non-reactive material called polytetrafluoroethylene, which is PTFE, which is used extensively in surgery. And they identified that new intimal growth actually goes down as long as you cover the one or the other surface of these stents with PTFE. And as you can see, 18 plus minus 0.3 compared to 72 nanomillimeters. And this problem, this reduction of neointimal hyperplasia is sustained over 56 days, raising a question that if we take a stent and cover it with PTFE, I'm sure they're going to perform better. So currently, we have multiple stents available. In my early days, we used to actually sew up the PTFE on a Palma stent and deploy them. But nowadays, the life has become a whole lot better. We have these PTFE covered stents available, both in balloon expandable as well as self-expanding form. Self-expanding are Vibon stents, and balloon expandable is Atrium's ICAS stent, which is also called Advanta V12 in the rest of the world. So what does it do? It actually reduces the contact. There's no contact between metal and vessel wall. There's no contact between metal and blood. And these stents can be deployed via small sheets nowadays, 7 to 11, depending upon the diameter of the stent graft. And these are different varieties of these stents which are available. So the question I have is, do we really need covered stents? As Jack mentioned before, we are becoming more and more gung-ho. A and B lesions, we usually treat them normally. However, we are becoming very interested in taking care of C and D lesions. And these C and D lesions can be taken care of because we have a variety of devices available now, re-entry devices, devices which can open total occlusion, about which you heard all day long. So we're looking at type C and D lesions, which are very important, which were sent to the surgical group to perform aortobifemoral bypass. And these are the kinds of lesions which we're looking at. As you can see, the first one is total beak-like appearance of aorta. Second one, aorta is completely occluded, and that's a long IMA. And on the right side, total occlusion of right iliac artery, which we are seeing a lot more in our practice. So what is the long-term durability? First paper that came out, because when we talk about whether these stents perform or not, we have to actually look at type 1 evidence. Unless the evidence is confirmatory that these stents actually perform well, I cannot answer the question posed to me by Dr. Golzar. So between 1997 and 2006, Chang's group actually looked at 171 patients. They performed endarterectomy of the femoral artery, followed by balloon angioplasty and covered stent placement. And they used all task C and D lesions. Stent grafts were utilized in 41% of patients and bare metal stent in 49%. Success were equal in both groups, but 5-year patency of bare metal stent was only 53%, where covered stent showed marked improvement at 87%. Sabri's group actually looked at 54 patients, 26 covered stent, 28 bare metal stent, and they also showed the patency of these stents, 92 to 94% respectively for covered stents. So they recommended the use of covered balloon expandable kissing stents is more useful in more complicated aortoiliac lesions. We also look at the biggest trial so far done with covered stents. It was done in Australia. It's called COBAST trial. They actually compared the bare metal stent and covered stent in randomized study. And they looked at only 168 iliac arteries stent placement in 125 patients. And they were followed only up to 18 months. And that's where the problem is. Up to 18 months, there's no significant difference in bare metal stenting versus covered stenting. So although COBAST trial shows the patency of these stents is definitely better, but at the level of 18 months, I totally do not really agree that that is a sufficient time to give us proper data. However, what came out through COBAST trial is very important, and that is type C and type D lesion tend to perform better. And over a period of time, if we follow these patients indefinitely, we'll see TAS C and D lesions will continue to do better. But what did we learn from COBAST trial? Initially, talking to COBAST trial, they were actually covering the lesions with covered stents. However, it was important that covered stents should be deployed from normal artery to normal artery, because stenosis occurs at the edge where PTFE meets the normal artery. Whereas in bare metal stent, the in-stent stenosis occur in the middle of the stent, as you saw in Dr. Montajme's case. And in CTO, entire recanalized vessel need to be covered. If they are leaving only spot stenting, they're bound to fail. Grimes looked at multiple articles, almost 51 articles, and he actually said primary patency for covered stent between 70 to 100% in first year. However, in 5-year primary patency rate goes as compared to bare metal stent, 63%, 83% for covered stent. Frederick Grimes' other work, 115 stent published in Journal of Endovascular Therapy in 2011, shows primary patency first year of 95.2%. However, it dropped significantly in his series to 74.4%. Peter Govard and their group in Belgium actually designed what Jack was talking about. Here, actually, a stent is placed in aorta, and 2 stents are placed in either iliac artery, creating what is called SERB, covered endovascular reconstruction of aortic bifurcation. They looked at their patients, mean follow-up only 10 months, and their 6-month patency was 95%, and secondary patency was 95 or even higher. Limb salvage was identified in 98% of patients. Now, this is my unpublished data. We have been performing these stents since 2004, as soon as atrial stents have appeared in the market. We did 201 stents, and bilateral stents were placed in 71. And as you can see, 30% of our patients showed significant amount of CTO, and on the other side, regular morbidities, which are commonly seen in these patients. These are the kinds of patients which we have treated, total occlusion of aorta. And then, as you can see, task C and D lesion are the bulks of these reconstructions. So we followed these patients with lifestyle questionnaires, random testing with CTA and Vitrea to identify how these stents actually look like inside the aorta. So this is one of our first cases, total occlusion, beak-like appearance of aorta. We could not enter when subintimally utilized an outback catheter to get in there, and then performed placement of a covered stent from the aorta all the way down to left iliac. Right iliac could not be open, so we went ahead and placed a fem-fem crossover bypass graft. As you can see here, 36 months follow-up, you can actually see stent strut in those covered images. And as the Vitrea probe goes through these stents, you can see the surface of the stent remains smooth. There is no atheroma prolapse, and that's why the patient's left iliac artery is completely open after 3 years. This patient has been followed with me for almost 8 years now, and she's still widely patent. So what are our results? Success rate is 100%, no immediate thrombosis, no stent-related complication, 1 access site complication because of angiocele. Over the period of time, this is almost 10 years, 38 patients have passed away. Follow-up is anywhere between 12 months to 76 months with 48 months mean. So what is the patency? After 201 patients, I have followed these patients personally for every 4 months for past as many years with ABI indices, lifestyle questionnaires, and palpation of the femoral arteries. The patency, only 2 stents went down in patients who are non-compliant. These are late occlusion, 27 and 29 months. ABI has improved from 0.4 to 0.7 and sustained over these many periods. So in conclusion, across the test, covered stent exhibit better long-term patency. There is no significant difference between bare metal stent or covered stent in task A and B lesions in short-term follow-up, but long-term data suggests better patency of covered stent. Data also suggests that covered stents are beneficial in very complex task C and D lesions. Kissing stents and calcified vessels tend to do very well when covered stents are placed, as it's evident by 76 months follow-up in our own data. To answer the question, covered stents in aortoiliac disease, do they perform better than bare metal stent? Answer is yes, they do. Thank you.
All right. So we're going to do our last talk, Dr. Miller.
That's great data. That's a great talk. Yeah, it's really good.
About renal artery stenosis. All right, thanks.
We'll go to the next talk.
So I was asked to speak on contemporary renal angioplasty. I don't think my whole slide is up there. Could you resize that? Thank you. I'm from Charlotte, North Carolina, interventional cardiologist, and had crossed paths with Joffer in the past. Disclosures here, principally regarding Artisan and Hercules, which I'll be talking about. So, as regards renal intervention, the 800-pound gorilla in the room is renal nerve denervation. There's no doubt about that. That is not this topic, but one way of formulating what renal artery angioplasty is about is that it is another way to modify the renin-angiotensin sympathetic nerve system. Maybe the original way, we could say. So, and in those trials of renal nerve denervation, renal artery stenosis patients have been excluded. My prediction is that the advent and use of renal nerve denervation will lead to the identification, because patients will be referred for intervention because of their uncontrolled hypertension and will be incidentally found to have renal artery stenosis. And I think once the devices are used in less than pristine vessels, used in type 1 diabetics, used in renal failure patients who don't have enough blood flow to cool the artery during a denervation procedure, we'll be seeing more renal artery stenosis caused by renal nerve denervation. So far, it's rare, thankfully so. So this is what's going on these days with renal artery angioplasty volumes. Down about 5 or 8% over the last, this is 2010, projected out to 2014. About 12% of the procedures there are POBA rather than renal artery stenting, and the U.S. accounts for about half of the worldwide volume in renal stenting. Back of the envelope calculation, 50 million hypertensives, 1% of them have significant renal artery stenosis. It means that we're treating about 1% of the potential patients who might benefit from angioplasty of their renal artery because of a critical and clinically significant stenosis. So this was a study that we were participating in, Hercules trial published last fall. It was a registry study of patients who have real renal artery stenosis, that is, not just the stenosis, but also the hypertension that goes along with it, uncontrolled hypertension on multiple medications. And this was Abbott Vascular's monorail system to get approval for the Herculink Elite system. 202 patients. We had 25 of those patients at our site, 241 lesions. The findings were that with intervention, overall there was no change in the use of medications. There was no change in renal function from pre-procedure to 9 months post. The restenosis rate by ultrasound was 10.5%, and the 2-year target vessel revascularization rate was 7%. One aspect of the study was that all the patients were to have had a BNP level done before and after the procedure. There was some preliminary studies that showed that perhaps BNP was a predictor of who would benefit from renal artery intervention. In this study, there was no relationship between the level of BNP and the response to blood pressure, the blood pressure response to renal stenting. There was a drop in BNP, but it was a scattergram. To me, not surprising, because BNP is made by the heart, and so you're trying to predict the effect of an intervention on a remote organ mediated by hypertension in the setting of multiple medications. Be that as it may, turns out BNP is yet another non-predictor of response to renal artery intervention. So the results of the study, single-arm study, was that it was effective at reducing blood pressure. Blood pressure, mean systolic pressure, went from 162 to the 140s, and that was immediately post-procedure, 1 month, 6 months, and its study ended 9 months. The higher your blood pressure at the time of your intervention, the greater the blood pressure drop. So the Patients whose blood pressure was greater than 180 had an almost 50-point reduction in blood pressure over 9 months. Likewise, less for 160 and 140. So, my take on Hercules is that this is contemporary renal angioplasty. It's effective when it's performed in patients who have renal vascular hypertension. And the operators in the study were able to perform the procedure safely. The MACE event rate was 1.3% instead of 17% in Astral. And there was no deterioration in renal function. It's the way that angioplasty should be done in the setting of what we're presented with clinically. So that brings up the issue of patient selection. And really, I'd say there's not been much change in this aspect of it. I'll go through it quickly. You should have a good clinical situation and a hemodynamically significant stenosis. A lot of the previous studies did not have one or the other, or both. The indications are uncontrolled blood pressure, impaired renal function because of ischemia, or the remote effects on the heart through the pressure effects causing LVH, diastolic dysfunction, heart failure. It's not indicated for medically controlled hypertension. So of those, be that as may, you have to keep in mind the limitations of imaging for renal artery stenosis. CT is the very patients who you're interested in, the ones that have an osteocalcified lesion. It's hard for CTA to deal with. MRA tends to have a false positive problem. Ultrasound is a very good modality when you can get a good ultrasound image of the renal artery. It does tend to fall down in patients who have had previous stenting. If you leave the stent hanging out in the aorta even a little bit, the blood rushing around those stent struts causes turbulence, which is the signal that you look for in Doppler ultrasound for determining the patient has a stenosis. And angiography is an invasive procedure with contrast. Probably more important than that is that angiographers are not very accurate in determining how bad the stenosis is by what they see on an angiogram. Because of that, if you're going to undertake this procedure, you're really obligated to confirm the physiology. Rough rule of thumb is that the pressure gradient, the peak pressure gradient should be greater than 20, mean pressure gradient greater than 10. Some people use 90% as the cutoff. You want to do the procedure in the right patient because the worst complication is the one that happens in the patient who does not need a procedure. In coronaries, there's a lot of interest in using radial access. The advantage of it is that a lot of these patients have concurrent femoral disease. A lot of the renal arteries are directed toward the toes. And with radial access, you have less bleeding complications compared to femoral access. The disadvantages are that for radial access, there's poor sheath and guide selection. The distance between the radial artery and the kidney is just too great for most patients to be able to lay a catheter there to do the intervention. To my mind, the brachial access really has no advantage over femoral. The complication rate is probably even higher. As regards pharmacotherapy, just a few things here. Very little in the way of scientifically valid analysis of what drugs to use for these patients. One randomized clinical trial was for ReaPro. In that study, the RESIST study, it was only effective when it was paired with embolic protection devices. And that was as determined by whether there was preservation of the GFR. So my approach is to tailor the pharmacologic therapy to prevent the complications of the procedure. Those are vessel spasm, contrast nephropathy, ischemia of the kidney, thrombosis in the vessel, perforation of the kidney, which can be a disastrous problem, or access site bleeding. And therefore, a la coronary intervention, the treatments, the pharmacology is hydration, vasodilators. I generally withhold ACE inhibitors on the day of the test because once you remove that renin released by the kidney, they tend to really drop their pressure quite a bit. Antiplatelet therapy, aspirin, and thienopyridine, and anticoagulation. This is a situation where I use heparin rather than Angiomax because it's reversible. And then most of these patients have other reasons they have coronary disease, they have peripheral vascular disease, and all of the Capri study, they probably ought to be on long-term antiplatelet therapy anyway. Fibromuscular dysplasia, as you may know, mostly seen in younger female patients. The estimates are 10% of renal artery stenosis. I'm not seeing that much. It gives a characteristic beaded appearance on the angiogram. Because it tends to be distal disease, it may be difficult to diagnose with a CT or an MRA. It's generally treated with balloon angioplasty very effectively. These patients also tend to have other sites for fibromuscular dysplasia. You ought to look. And for them, since the cure rate is so high, the follow-up is clinical rather than with serial ultrasound studies, again, because ultrasound may have trouble with the distal and diffuse nature of the disease in these patients. Embolic protection, something like in previous studies, 20 or 30% of patients have a deterioration in their renal function post-procedure. Non-renal embolization also occurs. The Astral study had 3 patients that underwent amputation of their leg because of embolization related to the way that angioplasty was performed. Emboli can occur and do occur with all steps of the angioplasty process. How often it occurs or how bad it is hard to know, but it does happen. Luckily, there's usually quite a bit of reserve renal function. No effective treatment for embolization, only prevention. The filters that can be used are for other uses and are not really well suited for the size and branching characteristics of a renal artery. So when they've been used, 80% of the devices contain visible debris. That RESIST study that I mentioned before showed that the filter devices were only effective when ReaPro was used also. What they also saw was that the platelet-rich particles in the filter were were diminished just as much by the use of a thiopyridine prior to the procedure as they were by the ReaPro. So my advice would be to use the least traumatic procedure technique that you can. Avoid scraping the aorta. Use low-profile devices. There's very good 14-based systems out there. Minimize the amount of contrast you use and match the size of the vessel accurately. You could consider embolic protection when patients have severe aortic disease to avoid aortic embolization into the renal artery, when they have a single kidney, when they have renal insufficiency and have less reserve. The Artisan trial that we're participating in is one looking at a lower profile covered stent device for renal use to try to prevent embolization from the balloon / stent deployment step of the procedure. Renal artery restenosis incidence varies. Like I said, in the Hercules study, it was 10.5% as measured by ultrasound, 7% by clinical criteria. The skip down to the proposed treatments: POBA, cutting balloon cryoplasty, brachytherapy, further stenting, all perform very poorly. You ought to avoid. The options are covered stents, a drug-eluting stent, or surgical bypass. The problem with drug-eluting stent, very good solution for patients who have a vessel that's the size of a coronary. That's not usually the case. My own approach is to use covered stents for treating restenosis, very effective. So in conclusion, as regards renal angioplasty, the right patient with the right lesion and the right physiology should get the right procedure. There's still demand for renal artery stenosis therapy. The challenge is to identify and treat the appropriate patients early enough to make a difference. And if you defer treating a patient with renal artery stenosis, you are, I think, obligated to make sure that that medical therapy is optimal. There's some issues remaining about equipment, especially for the lack of equipment for a radial artery approach. And finally, something that was touched on the morning sessions, regulatory and political issues will, in the future, put pressure on our medical decisions. I would say more about it, but I think the NSA might be listening, so. Thank you.
Can I ask one quick question? For distal protection on your kidneys, what are you using? How are you dealing with the fact that it's a short segment and you may have to pick one branch or the other? What do you tend to do?
Generally use the spider system, and like you said, you usually have to pick the dominant branch to park it in. Right. You're only going to be filtering half the blood that comes through, but it's better than none, I guess. Right. Most of the time, not using a filter. Yeah.
All right, we'll go ahead and go back to Amir. Thanks, Mike. Appreciate that. Hey, Amir, you're back on your bike live. It sounds like you're probably done. Do you want to show us some pictures, what your final results are?
Yeah, after we left you, we dilated the SFA popliteal, and as the post-PTA arteriogram was very impressive. It looked very nice, but because of the history of reocclusion, I decided to go ahead and put Viabon across the whole artery from origin all the way down to the popliteal runoff. Can you see the angios?
Yes, we can now, yeah.
Okay, this is the proximal segment, next one. And this is the distal, where is within the stent. Previous stent, next one. And this is the popliteal runoff, next. Next one. And next. All the way down, patent down to the foot. So hopefully that will keep this artery patent for a long time. There was only one area that it looked like the Viabon was a little bit compressed. And apparently we didn't get enough luminal gain at that place. That's why I believe that anytime you want to put a Viabon in, you ought to do a debulking prior to that, because there are lesions you just can't dilate with balloon. But anyhow, we're done, finished.
Thank you very much,
And
Amir.
Great work, Amir.
Excellent case,
Yeah.
beautiful results.
Very nicely done. Thank you.
Thank you so much.
Thank you.
We'll finish up with Dr. Mewison.
It's way past happy hour. So I have 2 or 3 cases. Jaffer had asked me to sort of go through 2 or 3 cases, kind of like show and tell. I'm not going to try to show you something like outrageously difficult or anything like that. It's more like things that we'd see on a daily basis in our practice. So the first one was a 68-year-old woman, and she had undergone by history a femoral tibial bypass 4 months prior at an outside hospital. And she came through wound care with a dehisced wound around the medial aspect of her knee. That was the original surgical wound, and she had undergone several hyperbaric treatments before we got consulted and take a look at her. So on physical exam, she had rest pain in her foot, She still had an unhealing toe also, which she claimed had never really healed, and did an ultrasound, and the graft was open. I couldn't really see the distal part of the graft, but the velocities were low in the femoral tibial bypass on the right side. So this is her angiogram. So this is the right leg that's affected, so we approach this from the left side. And you can see that the bypass on the right side is open proximally. And as we get down to the anastomosis with the perineal artery, and I'll show you some, actually there's a pretty decent pointer here. If you can see this lesion here, which is the anastomosis of the perineal artery, it looks like the surgeon did a patch. The graft comes in, there's a stenosis at the edge of the patch. There's a stenosis at the perineal artery as well, and then there's another stenosis, which is, I think, a very significant lesion in the tibioperineal trunk, heading back towards the circulation to feed the anterior tibial artery. So the question is, how would you treat this? Amir may want to put a Viabond in here, but I'm not so sure that would actually work in this case. She had a lot of stents, as you can see, in her iliac arteries, and her access was fairly, very, I thought her arteries were small and calcified, and she was a very fragile person. So I sort of ask you guys how would you? What I think is important here is that the lesion in the tibioperineal trunk, or actually the distal tibioperineal trunk, that feeds back the anterior tibial artery is the significant lesion, because if we can go back, you can see that the perineal artery has a very significant lesion distally. Her posterior tibial artery is occluded. So I can fix that perineal artery fairly easily, but the question is how to approach that other lesion, which would feed back, the entire knee and also the foot. And like I said, she had rest pain in her foot, most likely from her anterior circulation rather than the posterior circulation, which is very lacking in this case.
It looks like she might actually have a lesion there distal in the dorsalis pedis as well.
Well, interestingly, this is a reverse saphenous bypass, so it's not actually a patch. When you take the whole vein out, the proximal end of the vein is large and distal end is narrow. So when we reverse the vein, because of the valves, you reverse the vein, so bigger end is now anastomosed to the distal artery.
Yeah, it's not a patch.
And that's what it looks like, a patch, but it's really not a patch. And the significant stenosis right at the anastomosis, at the heel.
You think you can do a U-turn?
Yeah.
It's pretty tight.
Well, you can come from across first and balloon angioplasty the top one first and see how it looks.
Yeah, so I fix what's easy first, but I also know that once I fix the proximal lesion, it's sort of how you're going to fix the other lesion. And they're short focal lesions, so I figured I like to use stents, medicated stents like Zion stents in these. And I did all this through a 4 French sheath also because of her access. And so what I did after this is I went back to the original groin, and I saw that there was maybe a little bit of a nipple. I didn't know how long the stents had been occluded, but I was able to get back into the native circulation, sort of getting access, wire access through the occluded stent, get a catheter back into the popliteal artery. And then at that time, I was able to put a short little stent and fix it that way.
So did you leave the SFA and pop alone?
Yeah, because the graft was doing the work. Yeah.
And the reversal of flow now is showing a significant improved flow in the anterior tibial artery.
Mm-hmm. Yeah, and she healed. I just saw her like 2 weeks ago, and she completely healed her wound. Now, option B would have been, if I hadn't been able to do that, you could maybe theoretically come from the dorsalis pedis, and I was thinking about doing that perhaps. That would have been relatively easy to do that as well.
So how old was the graft?
4 months.
I probably would have tried a cutting one on that one.
No, the sutures are going to fall out. It's 4 months.
I don't think you tied them in tight.
No, but we have a monofilamentous proline. So when you use the cutting balloon, if it cuts, the entire thing unravels. So at 4-month level, I still doesn't have much sealing around the area yet.
So when would you feel comfortable using a cutting balloon? About how
after
long?
6 months to a
6
year.
months.
Yeah. But at this time, balloon angioplasty or putting a stent is just about the right thing to do. And most of the time, at 4 months, it's, you got to realize it's technical problem. When whosoever sewed the heel, put the stitch really too tight. And that's why, and the reason the graft will not fail is because you have reversal of flow. If there was no reversal of flow, the graft will fail.
I don't know why the surgeon decided to go into the perineal artery.
That's what my question was.
Yeah.
I think he should have just hooked it up at the trifurcation.
But I think it's a good bailout. If it fails, you can swing that graft back, I would think, into the anteriotibial circulation.
Could be done, yeah. Yeah. No, perineal bypass compared to anterior tibial is much tougher procedure.
Okay, the next case is a 72-year-old man. He was transferred emergently with a left popliteal aneurysm rupture. There was a CT scan, and I had talked to the ER, which was an outside hospital, but I never got the CAT scan. But the patient was emergently transferred, and on physical exam, this guy was really hurting quite a bit. He had a very large mass behind his knee, and his foot was mottled. He had no pedal pulses, but the foot was viable. He had a little bit of motor dysfunction, but I thought the motor dysfunction may have been too. He told me that he had that for quite a while, and I think it may have been the aneurysm, interfering with the surrounding nerves. But anyhow, so I came from the contralateral side. So he's supine on the table, and the proximal SFA is open, and it's probably the largest popliteal aneurysm that I've seen. And, quickly I got in there, and I tried for maybe 10, 15 minutes to get access into the reconstituted popliteal artery, but I just couldn't do it. I just had no clue where that opening was. It was like fishing, a needle in a haystack. But you can see it, I could see a whiff of contrast, so I thought, God, his popliteal is open, it's reconstituting, so you got to be able to get to that, right? So the patient is supine, he's a pretty generous, weight-wise kind of a person, and he was in pain and all that, and I thought, God, if I turn this guy around prone, it's going to be a pain to do that. So I asked the team to elevate his leg with some pillows and stuff, and I kind of went with a micro puncture set, tried to get back into the popliteal artery. And eventually I was able to do that, and I sent out an 014 guide wire, and I snared myself from above, and then I got a quick cross catheter into the popliteal artery, and I fixed all this with a Viabomb. The reason I'm showing this is that I was aiming, I thought, God, I might as well get my Viabomb covering the access in the popliteal artery so we won't have to deal with, holding pressure and all that stuff. And I did that, but the Viabomb completely jumped out of it. I don't know if you've experienced trying to put a Viabomb in a big balloon. It doesn't control well. It just completely pulled back. And so, but I had my proximal seal, so I was able to get a second one in there. And then once the second one, it stabilized in there, and I was able to just deploy it exactly where I wanted to.
Watermelon seed out because it was a little too big?
It does something funny. I don't understand really how it happens, but it just doesn't stay where you want it. You pull the string and the whole thing buckles and comes back. Yeah.
The reason for that is there's no support in that
That's right.
popliteal aneurysm. So when you dilate it, post placement of Viabomb, it has a tendency of pulling the distal end because it's not sealed up.
Correct. Yeah.
But it happened when you deployed this thing?
No, after ballooning. After ballooning?
I'm sorry, what was the
When
question?
did it migrate? When you deployed it?
Yeah, when you pull the string.
Yeah,
Okay.
that's what's
When you pull the string, you can see the catheter kind of curves. It's like it torques, and it doesn't stay in place. It's not anchored.
probably the same issue, that it's like doing it in midair.
Because it's so spacey,
Right.
Great.
And so here's the, you can see that his runoff, there was clearly evidence of embolization there in his foot, which is obviously what popliteal aneurysms do. They chronically, thromboembolize the runoff. But he stayed open. We've had very good patency with Viabonds for popliteal aneurysms.
One of the points I want to make it here before, Mark, you close, that it's very rare to find a ruptured popliteal aneurysm.
Yeah, that's true.
It's thrombosed, most of the time embolized, but rupture, I mean, as many years I've been in practice, I've never seen a rupture. No, it never ruptures because there's got so much thrombus.
When a popliteal aneurysm comes in thrombosed, I still try to get a CTA to see if there's a landing zone distally, because we've done several cases now where I go ahead and put the Viabond first and exclude all the thrombus, and then deal with the tibial runoff thrombolysis, so that you don't run the risk of running TPA into a thrombosed twirling aneurysm. And because there's been reports that you may actually further embolize, running TPA into a thrombosed aneurysm. This is a patient who has a right TMA, and he's got a plantar ulceration. He's a fairly young guy. So I'm dealing with this proximal SFA occlusion. Kind of like, okay, I'll be done in 10 minutes, right? And he reconstitutes his SFA, and his runoff is actually pretty decent, and you can see that he had a TMA in the past. He's diabetic. He's got small vessel disease in the foot. But the way I tackle these CTOs, I obviously use a quick cross, but I like the supracore guide wire, and I think that you kind of advance the guide wire, kind of go like this, and when the supracore stops, usually, you have to be careful because you don't want to go subintimal. I try to stay intraluminal as much as I can, then I switch for another guide wire. And so this is kind of the scenario. When your supracore does this kind of curving, it means there's something that is obviously blocking it. So I put in a straight glide after that, and even the glide wouldn't go. Then finally, I advanced the sheath further down, get more support, and then the glide went through. But you can see that the glide went through, but it doesn't look right. Yeah. It doesn't look right. So, true enough, you put your quick cross, and I'm a subintimal, right? I mean, you can see that. Okay, but if you appreciate that, it's kind of subintimal with a quick cross. You can tell that it's not in the vessel. So, I exchange for an 014 guide wire, and get my Outback device. One stick, I'm back in. I can see my wire float down, without any problem at all. But then I always check. Obviously, you have to check, right? And one thing that did surprise me is that usually at the reentry sites, your quick cross will kind of, it'll be a little resistance there, but this quick cross just went so easy. So I pull my 014, I get an angiogram, and what do you think of that angiogram there on the right side? I think I even have a...
Yeah, totally no lumen.
I mean, I'm still subintimal, right?
Yep.
So, you can't, but he's got flow, and what do you think about that collateral there? Does it mean that I am subintimal where the catheter is, but right at about Hunter's Canal, maybe it's a true lumen?
You're in and out.
It's kind of hard to tell.
Yeah.
So I'm asking myself, okay, do I start over again, get my Outback, try to repuncture, or do I actually go and try to get myself into the true lumen a little more distally? That's kind of what I opted to do, and so I went down, and the quick cross just, without any resistance, popped into the true lumen of the popliteal artery. And then, like Dr. Motarjame would do, it just kind of rebuild the whole thing with Viabonds.
Yeah.
It's a good argument for Pioneer. I like Outback, but you would see exactly where you were, and you see if there's some flaps starting, and you can be a little more. You could have shortened that a bit. But it's soft.
Okay, one more, last one. Is that okay, Jennifer?
Yeah,
Keep going.
Okay, this is a 64-year-old guy with right hip and butt claudication. And here's the angiogram. I'll give you the whole runoff. I mean, everything infrainguinally is fine. This is the lesion that I'm dealing with. So he's got classic buttock and hip claudication. So I think the external iliac artery probably contributes to a certain degree to his hip claudication, but clearly he's got buttock claudication, and his left internal iliac artery was diseased as well. So how would you treat this? Would you treat it? Or would you just treat the external and forget about the internal, or how would you do this?
I'm going to treat both of them. Because by treating external iliac alone, as you see, there's no collaterals, no branches coming off from there.
Right.
So his hip pain is contributory mainly because of the high-grade stenosis of it.
I agree. And how would you do that? There's a big mismatch between the common, the external, and what kind of stent, how would you do this?
Well, I think the internal, you could just easily balloon that and just, do a nice, soft, long balloon inflation and see what that looks like. And then you could always treat the external with angioplasty, see how that turns out, and then a self-expanding stent, and try not to cover that internal iliac artery.
I was saying that you do have to take the stent normal to normal. So I would like to have double puncture technique in this. I'm going to come crossover, place a wire in the internal, then come ipsilateral, take another wire up, and more or less kissing balloon there to make sure that there's no plaque shift to occlude the hypogastric completely. And then, depending upon the result of balloon angioplasty, you can make the decision whether you want to do a kissing stent there. You can kiss a small balloon expandable stent against a self-expanding or balloon expanding stent.
Right. What does the other hypogastric look like? It was diseased. It was diseased. How bad? I don't remember. We can go back.
Oh, God.
Actually, it's not too bad.
It's not that too bad, yeah.
I'm surprised that you would have cross-public collaterals to be, I think they're getting a big, I would just forget about that, the extra weapons. I'd go normal, it makes my mind,
So you're going to cover the hypogastric? If you put a Vibon up
You'd
top,
cover
then the
the-
hypogastric osteum will be covered.
Right, I don't think it matters.
But he's got right buttock classic claudication.
Buttock pain is coming from there, not from
Yeah.
external.
I mean, we see that in patients who embolize their hypogastric for aneurysms. You do that, and
Yeah.
30–50% of them with an intact.
Those are normal hypogastrics. This is disease, got cross-public collaterals, it's got collaterals from all the other places. You guys have talked about not worrying about covering all these collaterals, what the normal artery.
Yeah,
I think the difference, this is in an area where he's probably having symptoms. That's the reason to try. That's always an option if things go bad in the future, but it's definitely worth trying to preserve it, I think. And then how you do it, I mean, you
Okay,
can
I'll
do
show
it multiple
how I
ways.
did this.
What did you do?
Do we have any other opinions from the audience on how you treat this?
I can tell you the balloon angioplasty in that area in the internal is not going to stay open. That's, I think if you're going to treat it, you need to.
Fibrotic.
I was hoping to be able to put a short little medicated stent like a 3.5 and dilated it to like 4, 4.5, or 5. So anyhow, I got the first stent, and I think I took an 8/40 to flare it out into the common iliac artery, and then I just put an 014 through the sheath and went through the stent struts, and you can actually do that, fairly effectively. And so I got the 014 wire, and I did a little balloon first, and then I put the stent and got a nice result. And his symptoms completely went away.
What kind of stent was this?
This was a Zion's
In the
3.5.
internal, okay.
Yeah. Yeah, you can do. You can do that.
Mm-hmm.
Right. That's it.
Great, thank you so
Great
much.
stuff, sure.
I'm going to go ahead and adjourn. Thank you so much, everyone, for being here today. We had a great day, had some live cases, a lot of good cases that we got in today, and we'll see you tomorrow morning for the ISIS AAA summit, followed by carotid subclavian revascularization in the arterial room, and then further treatment of venous disease in the venous side, as well as IVC filter and further venous and DVT PE. Thank you.